Good afternoon, everyone, and it's a real pleasure for me to be here and be able to share with you a little bit of our story as NHS Blood and Transplant and our journey of process automation. NHS Blood and Transplant is one of about 450 organizations, together with 7,500 family practices, that collectively make up the United Kingdom National Health Service. It's a service that provides healthcare services to every resident of the United Kingdom free at the point of use. And with an annual spend of about £120 billion and with 1.3 million employees, the NHS is the fifth largest employer in the world after the US Department of Defense, the Chinese People's Liberation Army, Walmart, and McDonald's. So it's a huge operation to provide that healthcare service. NHSBT's role in that service really falls into three areas. We are responsible for providing a safe and reliable supply of blood to every hospital in England, working with just under 1 million blood donors every year to process about 1.7 million donations, or 6,000 units of blood a day, to service the needs of hospitals throughout the UK. Throughout England. Our Diagnostic and Therapeutic Services function is an area where we carry out a range of specialized testing for the NHS, specialized blood testing. We carry out immunology testing, tissue typing, and a range of services that the NHS would not otherwise have. And in that function, we also provide about 11,000 or 12,000 tissue implants every year. And we manage about 50% of the UK stem cell donations. And we were the first blood service in the world to start genetic sequencing of our stem cell donors in order to enable better matching of donors to recipients. And then we have our organ donation and transplantation function, where we work with families at what for them is an incredibly tragic and difficult time, to have a conversation about whether or not their loved one who has just died or is dying would have wanted to be an organ donor. And if they are, to make arrangements for their organs to be retrieved and transplanted, enabling 4,500 transplants to take place in the UK every year. But the transplant waiting list is 6,500 people. And therefore, on average, 3 people die every day in the UK waiting for an organ transplant. And that's a problem, and that's the problem I want to talk to you a little bit about this afternoon, and how we have attempted to address that. We attempt to address that by working very closely with transplant surgeons and with clinicians to improve the organ allocation processes and to improve the organ allocation schemes, to balance the sometimes competing priorities of equity, the principle of equal access to a transplant opportunity, utility, the idea that we will make maximum use of the organs that are available, and fairness, the idea that if someone's been waiting for a long time, they should probably have a degree of priority on the waiting list. But as we make changes to those allocation schemes, we hit upon a problem. And that problem is that they're becoming increasingly complex. What you're seeing on the screen are just some of the factors that are taken into consideration in our liver allocation scheme as it is currently being developed. They take into account physical factors about the donor and the potential recipient. They take into account the clinical situation of the donor and the recipient. And they take into account the geography, where each of them is based. And those factors aren't static. They change over time. And we learn more and more over time about how we could actually allocate more organs more effectively in order to try and ensure that everyone has the best chance possible of receiving a life-saving transplant. In our existing systems, however, this complexity was very hard to manage. Our systems were developed largely about 15 years ago. They were built as most applications were at that particular point in time. And the reality is, no one really knows the intricacies of those systems anymore. A lot of that knowledge is gone. That leads us to another problem: the time when this is all happening and how the decision process works. Because organ donation almost inevitably happens in the middle of the night, very often, and it's a very time-sensitive process. We have people who have to make decisions about who the recipient or the potential recipient should be, which order we should offer the organs out to the different transplant centers in order for them to make a decision about which recipients should receive those organs. And they have to do that in the shortest possible time, because the longer they take to get through the offering process, the longer that family is waiting to know what's going to happen in terms of donation. And that process was at least 96 steps long. And what you're seeing on the screen are just some of the workflow that used to apply to that process. And every box on the screen that is coded red, or colored red, sorry, is a step in that process that was a manual step that our highly skilled officers in our duty office had to work through for every single donor that we had. And the third problem that the observant among you might have spotted in the last two slides is across the bottom. The time that it took to make changes to our systems, because of the nature of the systems, because of the complexity of the systems, and the complexity of the workflow. It took us on average about 2 years to implement a new organ allocation scheme. That's 2 years when we could have had a more effective scheme, where we could have saved and improved more lives. So that's the problem that we wanted to solve. It was a problem that was exacerbated by the fact that there were always exceptions. And some of those exceptions we couldn't even manage in our systems. So we had a workaround. And that workaround was a whiteboard in the office where we put the name or the details of every urgent transplant patient on the waiting list. These are the patients who, if they didn't receive a transplant, most probably would not live for very much longer. And every time one of these patients got transplanted, or every time one of these patients sadly died, somebody in the office had to go and wipe off that particular line and retranscribe every line below it upon the list, so that we always had an up-to-date list of urgent transplant patients. This was not a process that we were very happy with. It's not a process that we felt was safe. And it wasn't a process that was enabling us to do our jobs as effectively as we might. That's the problem that we then came and spoke to IBM about. And in the course of those conversations, we stumbled on 3 products that collectively we thought would help us to address those problems: Blueworks Live, the Operational Decision Manager, and the Business Process Manager. Blueworks Live enables us to have a conversation with the people who are actually working in the office about the processes that they are actually following, to map them out in a way that they can understand and interpret them, and then to look to take that forward into some sort of automation tool. The Operational Decision Manager has enabled us to start to build flexible rules that we know we can change quickly because we understand how the rules are constructed within the context of the Decision Manager product. And the Business Process Manager gives us the supportive workflow that our staff need to automate that process and enable them to get on with the job of talking to the transplant centers and engaging and liaising with our staff in the donation hospitals to make sure that the families have the best possible experience of donation when that is a genuine possibility. And all of those products we've chosen to implement using the on-cloud version. The reason for that's quite straightforward. I do not want to have a whole team of people worrying about how many virtual machines we need in order to operate a particular piece of software. I do not want to have a whole team of people spending all their time worrying about how many or what particular variety of infrastructure we need to buy tomorrow. Our expertise, what we know how to do, is how to take technology and apply it to what we do best, saving and improving the lives of others through better, more effective organ allocation schemes. So this is what it starts to look like now. On October the 25th last year, we went live with the first of our systems, our heart allocation scheme, and we allocated the first heart in the world using a cloud-based system, the tools that I've just talked about. We started that process from scratch in March of last year, and we implemented it in October. That 2-year cycle was reduced to just 6 months. And in that process, we automated about 40 of the 96 steps that were previously involved in the process, a significant reduction in the number of manual steps that our staff have to go through in that time-critical moment. For me, the real beauty of it was that we were able to do that by integrating the new products to work very closely with our existing applications so that our staff didn't have a fundamentally different experience when they moved from an old application to a new application. The two came together. Sure, they got a much better look and feel, but they didn't have to go hopping between different applications to do their work. They were able to do it all in one seamlessly integrated environment, making use of our existing on-premise capability and the cloud capability in the cloud systems. We used the platform because we wanted repeatability and reusability. Much of what we have developed for our heart allocation schemes can be reused in all of the other allocation schemes that we're now on the process of developing. We wanted a platform because it allows us to iterate and improve over time. We know the platform will get better, and we don't have to do all of the work to make the platform get better. We've got other people, the good people in IBM, who are helping us with that and hopefully improving the platform as we go. And we were able, therefore, to map our end-to-end user journey and to build it all the way out as part of our process of digitization. We have now digitized everything from the point that our specialist nurses approach the family in the intensive care department right through to the point that we offer the organs for transplant to the transplant centers. And we're not stopping there. Later this year, we will implement a new liver allocation scheme, which we anticipate will save 50 lives every year because of the better allocation that we are able to implement. We will deploy a digitized transplant waiting list to enable the transplant centers to manage their patients digitally and update the information regularly so it is as current as possible throughout the process. Going back to that threefold piece about what process automation means, for us it is about that discovery piece. It's about being able to work with our users or our customers, understand what they need, engage with them in the process of identifying what the automation should look like, and engage them in the process of building it. We focus specifically in the automation process on the points of pain, whether that's cost, whether that's risk, whether that's delays. The pain point gave us a really solid business case in order to invest in this technology and be able to do some automation. But beyond all that, we needed the insights. We needed the insights that building a new technology gave us, but we also needed the insights that the technology is starting to give us. And as we move forward, we anticipate that we will actually be able to learn from the technology and improve the allocation schemes further, because we won't simply be analyzing data in a traditional statistical fashion. We'll be able to analyze the data that is now in our allocation schemes and improve them in real time to save and improve the lives of others. Because that's what this is really all about. This isn't about the technology. It isn't about how whizzy and fancy it all gets. It's about how we can use that technology to contribute to our core purpose and what we stand for as an organization. At NHS Blood and Transplant, we're proud to say that we stand for hope. We stand for life. And we stand for enabling people to do something extraordinary every day to save and improve the lives of others. To save and improve the lives of little girls like this, Phoebe, who's one of our blood recipients. And the process automation that we're able to carry out, working with the IBM tools, is about enabling us to do more of that and enabling us to be more effective at what we can be as an organization. Thank you very much.